Hi, my name is Mike Colvard. I'm a cataract surgeon and I have volunteered for many years with ECCE International. ECCE International is an organization that is dedicated to helping to prevent and reduce the incidence of reversible blindness around the world. In underdeveloped nations, there are millions of patients who are blinded by very advanced cataracts. And in this setting, it's generally understood that ECCE is the procedure of choice, both for practical and for financial reasons. In highly industrialized countries, I know there are hundreds, if not thousands, of highly talented, very well-trained Phaco surgeons who would like to volunteer their services internationally, but who feel uncomfortable performing ECCE, a procedure with which most of them have little experience. In this video, what I'd like to do is to present a technique which the skilled Phaco surgeon can easily adapt to perform ECCE. The emphasis will be on the slip and slide maneuver. This is a maneuver that allows the surgeon to bring the nucleus into the anterior chamber with a very minimal stress on the capsule or the zonules. Of course, once the nucleus is in the anterior chamber, it's very easy to deliver the nucleus from the eye and finish the case. The goal of the video, of course, is to encourage those of you who are Phaco surgeons to understand that you can perform this procedure very expertly. Even though you don't have a lot of experience with ECCE, your skills will serve you well in performing this procedure, and it's very easy for the skilled surgeon to pick up. So what I'd like to do now is just show you a couple of videos demonstrating this technique and the maneuver, particularly the slip and slide maneuver, which I think allows the Phaco surgeon to perform this ECCE procedure with ease. The two types of mature cataracts which one sees routinely is the flocculent white cataract and the very darkly brunescent cataract. We'll start with this white cataract. A fornix-based paritomy is created and the sclera is lightly cauterized, and a scleral tunnel incision is made. The scleral incision is easy to close securely, and also posterior placement of the sutures helps the sutures to be covered completely by conjunctiva postoperatively. We create an incision that is larger internally than externally. This creates a funnel through which we'll deliver the nucleus, and it's also a good idea to have a good scleral shelf which helps to prevent iris prolapse during the aspiration and irrigation process. With this white cataract, we're going to perform capsulorhexis, so we use trypan blue for better visualization. The OVD is placed in the anterior chamber, and the bubble is evacuated. Now next we place our side port, which will be used primarily to remove OVD and residual cortex after placement of the intraocular lens. We then perform capsulorhexis. With these mature white cataracts, of course, very often there is a flocculent material which obscures visualization. If you get a burst of white material, it's easy enough to aspirate this material and then carry on with the capsulorhexis. We want to make this capsulorhexis a fairly wide one so that we can be sure to deliver the nucleus through the capsulorhexis. Usually the capsulorhexis is made about 7 or 8 millimeters in diameter. Hydrodissection is then carried out in the same manner as with Phaco. We allow the nucleus to rise up a little bit and then pat it down just to make sure that we get a good fluid wave between the cortex and the posterior capsule. The incision is then enlarged. Once again, the internal incision is made larger or wider than the external incision, and this creates, as I said, a funnel through which we will deliver the nucleus. Now we want to bring the nucleus into the anterior chamber. We place OVD in the anterior chamber, and with the capsulotomy needle we impale the nucleus and slip the nucleus inferiorly and away from the dominant hand.
Then with the dominant hand, we place the OVD cannula under the nucleus, injecting OVD, which separates the posterior capsule from the posterior aspect of the nucleus. We then lift the nucleus completely into the anterior chamber, and we have a good layer of OVD that separates the posterior capsule and the posterior aspect of the nucleus. We slide the lens loop under the nucleus and deliver the lens. We then remove the OVD and the residual cortex using the Simcoe cannula. The incision can then be closed either with an interrupted or running 10-0 nylon suture. I prefer the running suture because in my hands it's faster. It's easy to adjust the tension of the sutures, and also there is only a single knot which can be placed within the incision. The conjunctiva is then placed over these sutures so that over the course of time the sutures will resorb in a way that's comfortable for the patients without exposure of the sutures. The OVD and residual cortex is then removed through the side port incision using the same Simcoe cannula. We then hydrate the side port as we do in Phaco, and this results in a very secure incision. Now the second type of cataract we see is the rock-hard wall-to-wall nucleus where there's very, very little cortex. In these cases it's probably wise not to do capsulorhexis. In these cases I do a can opener capsulotomy because these nuclei are so large it's very difficult to deliver them through a capsulorhexis incision. You notice also the incision itself is made larger in this case because we know that this will be a very large nucleus. We then use the slip and slide technique once again to bring the nucleus into the anterior chamber. The nucleus is impaled. It is slipped inferiorly and away from the OVD cannula. The OVD cannula is slid under the nucleus. At the same time, viscoelastic is injected. This helps to push the posterior capsule away and lifts the nucleus out of the capsular bag. We then bring the entire nucleus into the anterior chamber by lifting and injecting OVD. We create a very good layer of OVD protecting the posterior capsule and use our lens loop to deliver the nucleus. The slip and slide maneuver provides a highly reliable method which allows surgeons with little experience in performing ECCE to deliver the nucleus with safety and confidence. This is a technique for ECCE that can be easily performed by any experienced phaco surgeon.